Thank you very much, Hal, for that generous introduction. It's always daunting speaking after you. So I've been asked to talk through the clinical data on CDK4/6 inhibitors, but Mara and I have divided up the talk. I'm going to mostly talk about the data with palbociclib and a little bit with ribociclib, and then all the data with abemaciclib, Mara's going to come and talk through later. So first of all, early phase clinical trials. Most of what I'm going to talk about are the late phase studies. But Angela, I think we'll go forward, de Michel presented a couple of years ago at ASCO the phase 1 study of palbociclib in patients who are heavily pretreated. At this point, when the benefit rates that were seen in the study were relatively modest, but if you look at the lines of therapy, you're already beginning to see that those patients who were earlier in their treatment for advanced breast cancer were looking like they were getting more efficacy from palbociclib. And that, of course, led on to Rich Finn and colleagues to do the first study, Paloma 1, in patients who are AI sensitive. So the Paloma 1 study that you're probably all familiar with was 2 randomized phase 2 studies that were then done in 2 parts and brought together for the main analysis, all in postmenopausal women, first-line ER-positive, HER2-negative breast cancer, with PFS as the primary endpoint. And in this study, the median PFS was roughly doubled from 10.2 to 20.2 months, and is of course this study and the fact that it was done in 2 parts that were both positive led to the accelerated approval here in the US for palbociclib in this indication. Now the confirmatory study, Paloma 2, is being presented on Monday, again in postmenopausal women, 666 women, no prior aromatase inhibitor, so if they'd had it in the adjuvant setting, they had to have stopped at least 12 months previously, randomized between letrozole with or without palbociclib. And we know from the data publicly available that essentially Paloma 2 has reconfirmed the results seen in Paloma 1. So progression-free survival improved from 14 to 24 months with a hazard ratio of 0.428, with a modest improvement in response rate. The other study that we now know confirms the results of Paloma 1 is a very similar study to Paloma 2 that was done with ribociclib. And this has been announced just a couple of weeks ago in press release, as phase 3 studies are announced nowadays, that ribociclib, in a very similar design to Paloma 2, stopped at its interim analysis for efficacy. And this data is going to be presented later this year. Now, what about those patients who've progressed on aromatase inhibitors? So this is the Paloma 3 study that we presented at last year's New England Journal of Medicine. So this again was hormone receptor positive, HER2 negative metastatic breast cancer. In this study, we included both pre- and postmenopausal women. And here it's patients, pretty much the opposite situation, patients who had progressed on their prior endocrine therapy, either on therapy in advanced breast cancer or on or within 12 months of stopping in the adjuvant setting. And patients were allowed up to 1 line of chemotherapy. All premenopausal patients had to be on goserelin as well. And then patients were randomized 2 to 1 between the combination of palbociclib and fulvestrant, or placebo and fulvestrant. So the data we published at New England Journal showed again that there was a highly significant improvement in median progression-free survival from 3.8 months on placebo fulvestrant to 9.2 months with palbociclib fulvestrant, a hazard ratio of 0.42, highly significant. Now, the side effects of palbociclib do, to a certain extent, unblind a blinded study. So an audit was done with central blinded review, and that was very consistent with the primary analysis, with a hazard ratio of 0.27. Now, we've then updated this data, published just a couple of months ago with longer follow-up. So the first results of Paloma 3 were reported really quite early because the study was so positive at the interim. And really longer follow-up has confirmed essentially identical results with a hazard ratio of 0.46, confirming the efficacy of palbociclib in this population. So what about subgroups of benefit? Across all the pre-specified subgroups, there was consistent benefit for palbociclib. And the one I just want to show you in particular from this slide is pre versus postmenopausal women, and evidence of consistent benefit from palbociclib in both pre and postmenopausal women. Now, in the updated analysis, we were also able to have a good look at response. Many patients hadn't had the opportunity to get a confirmed response in our initial analysis. So in the updated analysis, we can now see that there's quite a significant improvement in confirmed response rates by the addition of palbociclib to fulvestrant. In the intention to treat population, up to a 19% response rate with the combination. But in those who had measurable disease at baseline, a 25% confirmed response rate. And I think when we think about this population clinically, I think this is quite an important response rate, because now you're getting on the par with chemotherapy. So for these patients, the choice you face in the clinic is often the choice between cytotoxic chemotherapy and endocrine therapy combinations. And one of the things that is reassuring when faced that decision is the response rate you get with this combination is very comparable with chemotherapy. Now, what about adverse effects? Now, as you know with these drugs, they have very characteristic side effect of neutropenia and bone marrow suppression from CDK4/6 function in the bone marrow. So in Paloma 3, there was overall an 80% rate of neutropenia, and over half of that was grade 3 or 4, so an over 60% grade 3 or 4 neutropenia rate, as well as a lower rate of anemia and thrombocytopenia. Other than the bone marrow suppression, most of which, of course, is asymptomatic, the other side effects that were modestly increased with palbociclib was there is a small increase in fatigue on palbociclib, an increase in nausea that's very small. There's an increase in alopecia, all of which is essentially grade 1, as well as some small increase in diarrhea and stomatitis in a few patients. Now, the neutropenia in particular leads to the need to have multiple dose interruptions. So half patients in the study required dose interruptions with relatively frequent cycle delays and dose reductions. And provided the neutropenia is managed in this way, actually the incidence of serious adverse events was similar, numerically less in the palbociclib arm. And there was also no rate of febrile neutropenia. So although a lot of grade 3 and grade 4 neutropenia is seen with these agents, that does not translate to increased rates of febrile neutropenia when managed with appropriate dose delays and potentially dose management and dose reductions. And it's very clear that although there's clearly neutropenia, neutrophil function is not affected by these agents. So the organizers have prepared a couple of patient presentations about their perspective of palbociclib before we go and talk to the PROs. So I don't know how we get these to work.
I think that first day,
Okay.
I know she explained it, but I was kind of in shock and didn't take it all in. And they sent me home with the drug sheet on it. And when I read it, I had told her I didn't want to do IV chemotherapy, and those were the same side effects that were listed. So I was very scared about taking that drug, and so I called the nurse, and she wanted me to come in, and she explained it, and then the doctor met with me also to say that there are, of course, possible side effects, but the other ladies that had been on it longer than I had, that they really weren't having a lot of those side effects. So that reassured me that that would be a good thing to go on.
I didn't read the sheet with the possible side effects because I'm the type that if it's possible I could get it, I start imagining that I would get it. And I didn't. I mean, the side effects were very minimal, and it was a very good experience.
Okay, well, these are some fantastic thoughts. So, so now let's look at this. So this is the data on the patient-reported outcomes from Paloma 3. So first of all, this is a global quality of life here on palbociclib and placebo. So overall on the study, there was a reduction in global quality of life on the placebo arm, but quality of life was maintained on those on palbociclib. And emotional functioning actually improved in patients on palbociclib. Now, to look at the overall score in a different way, this is time to deterioration in quality of life. So you can see there's a more rapid decline in quality of life, or time to decrease in quality of life on those on placebo, with a relative improvement on those in palbociclib. And if you look at the individual factors on what was actually driving patients to report the differences here, was if you look at the individual symptom scales on the C30 scale, those that were significantly improved with palbociclib versus placebo was an improvement in nausea and vomiting, but in particular reporting of less pain for those patients on palbociclib. But it's important that there is actually one symptom scale that was clearly worse for patients on palbociclib, and that was upset by hair loss, clearly reflecting those patients who do get some hair thinning and grade 1 alopecia on palbociclib. So what about predicting sensitivity to palbociclib? Clearly this is an important question because this is a very broad patient population. So the Paloma 1 trial set out to try and do this prospectively. So as I mentioned in the start, they did 2 parts of the study. The first was unselected, here in the left, and then the study was stopped and then reopened in a second part, which was essentially driven by amplification of cyclin D1. And there was clear benefit seen in both these subsets. So the first attempt to try and identify a biomarker for palbociclib was relatively unsuccessful. So what about biomarker analysis in Paloma 3? So we've done quite a lot of biomarker analysis in Paloma 3. So first of all, what about hormone receptor staining? So this is variability in hormone receptor staining here for the estrogen receptor from very strong to weak, and the hazard ratio for benefit, and the same for progesterone receptor expression, strong to weak. And overall, the p-value here tells you if there's any evidence of a consistent effect, and there isn't an evidence of consistent effect. So it appears to be that those who have strong hormone receptor expression were doing as well as those patients who had weaker hormone receptor expression. Then to look at mutations in the tumor and whether they correlated with benefit, we used liquid biopsies. The fact, obviously, that tumors, especially in metastatic breast cancer, release their free DNA into the bloodstream, and this allows you to interrogate the mutations present in the tumor. So the first mutation we looked at was PIK3CA, which of course is the most common mutation in estrogen receptor positive breast cancer. And those patients who had a PIK3CA mutation detected in their blood at baseline going into the study had very similar outcome, both on fulvestrant and on palbociclib, with the same benefit in whether the mutation was detected or not. And then the next most common mutation found in metastatic breast cancer that we've looked at are estrogen receptor mutations that Hal introduced in his introduction, which are acquired in about 20% of metastatic breast cancer that have progressed on prior endocrine therapy. Now we're beginning to get a real understanding that these are potentially important for response to therapy. And one of the studies we showed at AACR and is coming out in the JCO tomorrow, I believe, was where we looked at estrogen receptor mutations in the SOPHIA study. Now, this was a randomized study that randomized over 700 patients between exemestane and fulvestrant at the 250 milligram dose. We only had a subset of plasma samples to look at in the study, but looking at those patients who went into the study with an estrogen receptor mutation in their blood, they did very poorly if they were randomized to exemestane and relatively better on fulvestrant. Whereas those patients that were going in without a mutation detected did relatively the same on exemestane and a 250 milligram dose of fulvestrant, which is, of course, a bit historical nowadays compared to historical dosing. But clearly, if you've got a mutation, it's potentially better to be on fulvestrant than exemestane. What we've then gone is looked at ESR1 mutations in the Paloma 3 going in, and you see that actually then on fulvestrant, they do moderately well, but they also get additional benefit from being on palbociclib. And these mutants that do poorly on other treatments seem to do relatively well treated with a combination of fulvestrant and palbociclib. So again, unable to differentiate who actually benefits from palbociclib. Now, what about preclinical studies of palbociclib resistance? Who goes on to, what are the mechanisms that lead to resistance of palbociclib? Now, we've got no data of this at the moment in the clinic, but just to show you a little bit of our data that we've generated in the lab, where we've made both cell lines and some xenografts resistant to CDK4/6 inhibitors. So here are two breast cancer cell lines that initially are very sensitive to palbociclib and then have been grown in palbociclib until they've become resistant. In one, you can see that they get amplification of cyclin E1 in their tumor that leads to them to become resistant to CDK4/6 because cyclin E1 activates CDK2 as a mechanism of resistance. In another cell line, it loses retinoblastoma, effectively the main target of CDK4/6, to become resistant. And we've also now shown in primary xenograft models that you also see loss of RB as a mechanism of resistance to cyclin-dependent kinase inhibitors in vivo in xenograft models. Here, one treated with ribociclib, LEE, until it becomes resistant. And at the point of resistance, you begin to lose RB in a lot of the tumors. So we're clearly also beginning to get a handle on what drives resistance to palbociclib, and this will be very important when we think about planning treatment afterwards. So what about use of CDK4/6 inhibitors in the clinic? How do we put this data together? So if we think about patients who are presenting for the first time with advanced breast cancer, how do we end up having to think about where these goes? Now, this is my schema. I think how we're going to talk about this a little bit later. Clearly, for those patients who are AI sensitive, who are endocrine naive or have had quite a gap since their adjuvant AI, or they've relapsed on tamoxifen, you have letrozole and palbociclib from Paloma 1 and now Paloma 2. But, there is potentially a role in patients who are endocrine naive, who've got low volume disease, to still consider the use of an aromatase inhibitor alone. In those patients who are AI resistant, they're relapsing on their aromatase inhibitor, and with MA17R tomorrow, potentially we'll be continuing aromatase inhibitors longer than 5 years. So this population is going to grow. This is the population where we have Paloma 3 for the combination of fulvestrant and palbociclib. And then there are a small number of patients who present with organ failure when they relapse, and there we may still need to safely use chemotherapy before potentially coming back to palbociclib. Now, is there anything that's going to change this? Now, what's certainly going to change this is the other CDK4/6 inhibitor studies that are coming through. We're waiting to see what we see in Mona Lisa 2 and then the abemaciclib studies. But the other thing that potentially might change this, which Hal mentioned, is Falcon, which is the first line study that looked at Arimidex versus fulvestrant. And quite how that's going to position how we treat these women, we will find out in ESMO this year. So in summary, palbociclib has shown high activity in randomized studies in Paloma 1 and 2 in that initial endocrine therapy combination with letrozole, but in Paloma 3, those patients who are progressing on prior endocrine therapy. And overall, palbociclib is very well tolerated from symptomatic side effects, although neutropenia is frequent. And although we have looked, so far we have not been able to identify any biomarkers of sensitivity beyond being hormone receptor positive and HER2 negative. Thank you.